Good good evening everyone. Myself Manasa is a second year MBBS student. Today I'll be speaking a few words about the retinoblastoma under the headings pathology, diagnosis and the modern management. Now let's go to the introduction and definition. What is retinoblastoma? Retinoblastoma is actually a rare, rapidly growing malignant tumor originating in the retinal photoreceptor precursor cells. Typically, retinoblastoma presents in infancy and early childhood. Most cases are diagnosed before the age of 5. Early detection is critical for survival, globe salvage, and visual outcome. Moving on to the global incidence. Global incidence is approximately 1 in 15,000 to 20,000 live births. Survival exceeds 95% with early management in resource rich settings but is substantially lower where the access is limited. What is the genetic basis and what is the pathophysiology behind the retinoblastoma? RB1 tumor suppressor gene located on the chromosome 13q14 loss of function mutations drive tumorigenesis. Knudsen's two-hit hypothesis, that is, both alleles must be inactivated. It's like either the germline plus somatic or it might be two somatic hits. RB1 loss disrupts cell cycle control E to F RB pathway, permitting unchecked retinal cell proliferation. Moving on to the hereditary versus non-hereditary retinoblastoma. Germline hereditary, it constitutes for about 40%. RB1 mutation in all cells, often bilateral, earlier onset, risk of second primary tumors. Whereas in somatic, that is sporadic, it constitutes 60%. Mutations limited to retinal cells, and it is usually unilateral, single tumor focus. The difference between the germline and somatic is RB1 mutation is in a germline we can see the mutation in all cells, but whereas in somatic, that is sporadic, the mutations are limited to only to the retinal cells. And in germline there is always a bilateral involvement, whereas in somatic there is only unilateral. It's unilateral. Hence, genetic testing and family counseling are essential for all the hereditary cases. Cardinal clinical sign, leukocoria. What is leukocoria? Leukocoria is nothing but a white reflex, or it looks like a cat eye, which is the most common presenting sign of retinoblastoma. It is often first noticed in flash photography or by the caregivers. The intensity of the leukocoria depends on the tumor size and the location. So it do have a variable intensity depending on the tumor and depending upon the location of the tumor and the size of the tumor. Any leukocoria mandates urgent ophthalmic evaluation and imaging under specialist care. Next is strabismus. Common presenting sign when fixation is disrupted by a retinal tumor may be the first visible abnormality. Strabismus would be the first visible abnormality. Redness or inflammation. Persistent unilateral redness, pain or orbital swelling may indicate advanced intraocular disease or secondary inflammation. Visual impairment. Poor visual behavior, nystagmus or asymmetric visual responses warrant evaluation for an intraocular mass. Diagnostic workup and examination. Comprehensive ophthalmic examination. It often requires examination under the anesthesia in the infants. Indirect ophthalmoscopy and wide field fundus imaging to document the tumor size, location and seeding. Ancillary testing, visual assessment, intraocular pressure and documentation with photographs for serial monitoring. Comes to the next is advanced diagnostic imaging. In this, B-scan ocular ultrasound, which is sensitive for intraocular mass calcification and vitreous seeding. MRI is preferred because through this we can assess the optic nerve invasion, extrascleral extension and intracranial disease without ionizing radiation. Avoid CT when possible due to the radiation exposure and risk in the young children. So, in the advanced diagnostic imaging, MRI is preferred very much than compared to the CT because CT causes radiation exposure and risk in the children. Next, the staging. What is the staging? And the staging, we are following the international classification for intraocular retinoblastoma, where the retinoblastoma is staged as group A3, A3E, A3B, C3D, and E. Group A3E categorizes tumor size, location, and seeding to guide prognosis and treatment selection. Group A3B indicates small focal tumors for good prognosis for eye salvage. Group C3D indicates local seeding or large tumors for intermediate prognosis, multimodal therapy often needed. Group E, extensive disease for low likelihood of salvage, enucleation frequently indicated. Next comes to the understanding the pediatric ocular malignancy. A concise visual primer on retinoblastoma, the most common intraocular cancer of the childhood. This deck summarizes the genetics, clinical features, modern classification, and current group sparing treatment approaches clinicians use today. Biology of the RB1 mutations. Origin. Retinoblastoma arises from the immature retinal precursor cells when key tumor suppressor pathways fail. Primer genetic driver, biallelic inactivation of the RB1 gene, loss of functional retinoblastoma protein permits unchecked cell cycle progression. Alternate oncogene. MYCN amplification can produce an RB1 independent aggressive subset seen in some unilateral cases. Laterality. Unilateral diseases constitute about 60 to 70% and bilateral diseases constitute about 30 to 40%. Often it is caused by germline RB1 mutation. Germline RB1 mutations confer hereditary risk, screen family members, and plan long-term surveillance. Clinical presentation and international classification. Key presenting points. Leukocoria, which is a white pupil reflex on flash photography, most common and the earliest sign. Strabismus is the misalignment from decreased vision or a paracentral tumor. Other findings are visual loss, ocular redness, anterior segment extension in advanced disease. International classification, it is retinoblastoma is classified internationally into groups A to E, prognostic staging that guides the treatment. Group A, small tumors confined to the retina, excellent salvage potential. Group B to C, larger or posterior tumors, moderate risk, focal plus chemoreduction effective. Group D, diffuse vitreous seeding, high risk for globe loss without targeted therapy. Group E, extensive disease, anterior segment involvement, often requires enucleation. The paradigm shift in the treatment. Intra-arterial chemotherapy, targeted delivery of the high-dose chemotherapy via the ophthalmic artery dramatically improves local control and reduces systemic toxicity. Through the intra-arterial chemotherapy, there is a targeted delivery of the high-dose chemotherapy via the ophthalmic artery, dramatically improves local control and reduces systemic toxicity. Intravitreal chemotherapy, there is direct vitreous injection for refractory vitreous seeds combined with safety protocols to prevent extraocular speed. Focal consolidation, transpupillary thermotherapy, laser through focal consolidation, transpupillary thermotherapy, laser photocoagulation, and cryotherapy remain essential adjuncts to ablate residual lesions. From enucleation to preservation. While enucleation is still indicated for advanced unsalvageable eyes, modern multimodal therapies prioritizes global preservation and vision when safe. Thank you. This was about the retinoblastoma in a brief, and thank you